spent a lot of time talking about abuse and dependency and tolerance and withdrawal and those terms and the way we used to use them and the way we still use them now. A lot of those principles are still in use, but I'm going to quickly go through what the DSM-5 TR calls them, because we talk about a category of conditions that are quote-unquote substance-related and addictive disorders, close quotes. The DSM-5 uses the adjective addictive, but in this section of the DSM, you have the use disorders, the substance use disorders, alcohol use disorder, opiate use disorder, cannabis use disorder, okay, not abuse and not dependency. Those have been supplanted by use disorders, and they've been subsumed. So now you see criteria that we used to see under abuse and dependency, and they're under one diagnosis now, which is much better. I agree, this is an improvement. But you also see the intoxication diagnoses, so you can diagnose alcohol intoxication, you can diagnose cannabis intoxication, right, when a person is in the hospital or in the emergency room and they're currently under the influence and they are exhibiting signs of intoxication. There are withdrawal diagnoses where applicable. Okay, again, some substances do not have an attendant physical withdrawal syndrome that you would diagnose in the emergency room or that you would treat. Substance-induced mental disorders is another category of diagnoses. For example, major mood and psychotic disorders that are due to a substance. So you would say, for example, alcohol-induced depression or stimulant-induced bipolar disorder. It's not really a bipolar disorder, but that's what it's called. And then you have the catch-all categories, the wastebasket categories, unspecified substance-related disorder, which we would have called substance use disorder, not otherwise specified in DSM-4. With hallucinogens, you have a special category called hallucinogen persisting perception disorder, which is a very specific condition that's defined as following cessation of use, re-experiencing of one or more of the perceptual symptoms that were experienced while intoxicated with the hallucinogen. For example, geometric hallucinations, flashes of color, intensified colors. One of my favorite effects of psilocybin is the bright colors. It's amazing. And after images, trails of images of moving objects, that's called palinopsia, or halos, and macropsia or micropsia, which I'm not going to define for the interest of time here, but are really fascinating that I highly encourage you to look up. So the DSM-5 designates 10 separate classes of drugs: alcohol, caffeine, cannabis, hallucinogens, inhalants. Some of these are very broad. Opioids, which would include the opiates, medications that are naturally derived from poppies, and synthetic opioids. Sedative hypnotics, again, covering lots of classes, benzodiazepines, barbiturates, and non-benzodiazepine, Z-drugs, and other drugs, and stimulants, including amphetamine-type substances and cocaine, as well as tobacco and that wastebasket catch-all other substances. And these substances, according to the DSM-5, these substances produce such an intense activation of the reward system that normal activities may be neglected. Here you see echoes of the compulsive nature of dependency. But again, because we're not talking about abuse or dependency, we can talk about any and all of the above when we're talking about a substance use disorder. The neurobiological roots of substance use disorders for some individuals can be seen in their behaviors long before the onset of actual substance use. For example, lower levels of self-control in general. And so again, those premonitory individual characteristics, idiosyncratic behaviors, impulsivity or compulsivity, and other things, it makes sense when we're conceptualizing these conditions as brain diseases of the brain. Furthermore, though, using substances because of those predispositions, those tendencies to use, compounds that innate impairment of brain inhibitory mechanisms and the proclivity and the likelihood that one will use, because using the drug has a negative impact on brain inhibitory mechanisms. So gosh, if that's true, we're in trouble. It's theoretical, but research does suggest that. Again, we currently use the terms substance use disorder and substance-induced disorder because they are less ambiguous when we compare them to colloquial use. We always have used operationally defined definitions in the DSM-IV. They've always been operationally defined, very specifically, and so we can quantify them. But there is less ambiguity because people are not using use disorder. That's not in colloquial use. And also, the term use disorder is less stigmatizing than saying that somebody is addicted or abusing or is dependent. We have to say that that person suffers from this substance use disorder, a use disorder. There's no way to use that as an adjective or a noun and say that a noun to describe a person. So you can't say they're an alcoholic or they're a heroin addict. That's the old terminology. Now you have to say that person suffers from alcohol use disorder. That person has alcohol use disorder. That person meets criteria for alcohol use disorder. You can't say that person is alcohol use disorder, and you can't say that that person is doing anything, abusing or etc. And so it's less stigmatizing. And language is important, and those subtleties of language are important. I don't like to say that somebody is anything, is bipolar. I'd rather say that that person has bipolar, that they inherited bipolar disorder. But to say, and even patients say it, I'm bipolar. And and I call myself an addict. I'm okay with the term, so you know that it's okay. But it can have a negative connotation. It does have a negative connotation. And some people are stigmatized by it, and some people's feelings are hurt by it, and some people don't want to go to meetings because they don't want to be known as an addict or an alcoholic. There it is again, I equal my disease. And so it's better, this terminology is better. And it's more accurate. It describes better because we're not saying anything about tolerance or withdrawal. We're not implying that because we say dependence, which would be a false implication under the old nosology, which caused confusion. Now we're just saying use disorder, intemperate use, and inability to control despite negative consequences. So I also should note that in this section of the DSM-5, the so-called behavioral addictions are not included, with the exception of gambling disorder, which is its own separate thing, and the eating disorders. Other behavioral addictions, including sex, shopping, exercising, we see that in the eating disorders, and internet gaming and other behaviors. And the reason is because there's insufficient peer-reviewed evidence to establish the diagnostic criteria needed to identify those behaviors as mental disorders. And so we're not saying that they don't exist, that people aren't addicted to sex and internet gaming, but we just haven't been able to look at the research, the committees that the American Psychiatric Association has set up, investigatory committees, and we just haven't been able to come up with any definitive markers for those conditions and definitive diagnostic criteria that seem to have validity and that have been validated by research findings. So that's why they don't appear. But you do have the sort of the catch-all other phrase, and I would certainly not hesitate to diagnose addiction to those if, as a clinician, I see evidence of this. So I'm not going to go through every substance use disorder or substance use intoxication or withdrawal, etc., but just in general, and this applies, for example, to alcohol, cannabis, and opioids, just to give you a good example. And they all say that the condition consists of, the core criterion is, quote, a problematic pattern of use leading to clinically significant impairment or distress as manifested by at least two of the following occurring within a 12-month period. And by clinically significant, we mean it results in treatment or the need for treatment. Patients will present for treatment or their families. It means that it comes to the attention of a clinician. and there is cause for a clinician to intervene. That's what we mean by clinically significant. Now, I've paraphrased these slightly to make them apply generally. Number one, the substance is often taken in larger amounts or over a longer period than was intended. Number two, there's a persistent desire or unsuccessful efforts to cut down or control use. Number three, a great deal of time is spent in activities necessary to obtain the substance, use the drug, or recover from its effects. Number four, craving or strong desire or urge to use. Number five, recurrent use resulting in a failure to fulfill major role obligations at work, school, or home. Number six, continued use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the substance. These problems can be pre-existing, like marital problems, for example. But if continued drinking leads to divorce, then even though the drinking didn't cause the marital difficulties, it certainly exacerbated them. 7, important social, occupational, or recreational activities are given up or reduced because of use. 8, recurrent use in situations in which it is physically hazardous. 9, continued use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. 10, tolerance, as defined by either of the following. A need for markedly increased amounts of the drug to achieve intoxication or desired effect. And B, markedly diminished effect with continued use of the same amount of the substance. 11, withdrawal, as manifested by either of the following. A, the characteristic withdrawal syndrome particular to that drug. And B, the drug or a closely related substance is taken to relieve or avoid withdrawal symptoms. Noting that not all substances have criterion 11, such as, for example, PCP, hallucinogens, and inhalants. You do see tolerance with those substances, but you don't see a physical withdrawal syndrome. None has been identified. So that is generally the current nosology. There's a lot more. There are countless specifiers. In early remission, meaning at least 3 months sobriety, but less than a year, or in sustained remission, which is more than 12 months of continuous sobriety, more than a year. Remission means that after full criteria have been satisfied for one of these diagnoses, none of the criteria are met, with the exception of criterion number 4, craving, a strong desire to use. You can have a strong desire to use and be considered in remission if you haven't used the substance. All of the other criteria, though, have to be absent for you to be in remission, and you have to have that for at least 3 months. And there's another specifier where you say whether or not the individual is in a controlled environment. So, for example, if a person is in rehab, usually, or a hospital, or perhaps a prison, then when applicable, you say in sustained remission in a controlled environment. You also have severity specifiers, mild, moderate, or severe, depending on the number of criteria satisfied, and then all the combinations. Mild in sustained remission, moderate in early remission, severe in early remission in a controlled environment, etc. And thank you for listening. As always, comments are welcome.